Thank you. First of all, I want to really thank Dr. Rozycki, Dr. Feliciano for endowing this lectureship and really having the foresight to put this forth. I really learned a lot going through this and doing this. Dean Warren is the father of selective shunts, the distal splenorenal shunt. And I wanted to talk about lessons learned. And I really want to focus on his life as a researcher and as a surgeon. Focus on research and development of the selective shunt. As disclosure, I did a fellowship in portal hypertension at Emory under Dr. Warren's direction. So I knew Dr. Warren, and I've done the distal splenorenal shunt, and I also know a lot about how it came to pass. I want to thank John Sweeney, Mike Henderson, and their archives of the American College of Surgeons for some photographs that I have of Dr. Warren. This is what I'm not going to talk about. Dr. Warren was president of so many organizations: American College of Surgeons, American Surgical Association, Southern Surgical Association, Society for Surgery of the Alimentary Tract. He was born in Miami, Florida. He enlisted as a Marine in 1943 to fight for his country. The Marines identified that this guy was too smart to send overseas to Guadalcanal to be chopped up by Marine gunfire, okay? They sent him instead to Dartmouth College. He then graduated from there, went on to Johns Hopkins to graduate Alpha Omega Alpha Medical Honor Society. He did a surgical training at Hopkins, Michigan, and Barnes. In 1955, he moved as an assistant professor to the University of Virginia. In 1956, he was selected as a John and Mary Markle Scholar. At that point in time, these scholarships were very, very prestigious and given out to a small number of academic physicians throughout the United States to supply research funding. He began his studies on portal hypertension. And this is some of the things that he was looking at. He was looking at whether or not there was hepatopedal, or towards the liver, or hepatofugal, away from the liver. And he did this either by doing a selective venous phase of a SMA arteriogram, or by sticking the spleen and injecting dye, finding the splenic vein, the coronary vein, the portal vein, and this is an example of hepatopedal blood flow. Well, let's start with the science of portal hypertension and portal systemic shunts. It goes back to 1877. Nicholas Eck was a Russian military surgeon. He published one seminal paper in his career on the Eck fistula, which was basically a portocaval shunt. In it, to create this portocaval shunt, he took arterial silk, or silk sutures, and sutured the two walls of the portal vein and the inferior vena cava together, and then took these specially designed scissors somehow after the quote-unquote anastomosis was made to actually create the fistula between the portal vein and the inferior vena cava. Then he ligated the portal vein distally. This is his unique experiment. He took and created the Eck fistula in 8 dogs. One dog lived for 2.5 months and escaped. And based upon that one dog, he concluded that this was a safe operation and should be done in man to control ascites. But let's look at all the data. He had operative death in 7, 88% operative mortality. I submit that his analysis of his own data was somehow lacking. Pavlov is a 44-year-old Russian in 1893. He won the Nobel Prize in Medicine for his work in conditioned reflex and his study of digestion in awake, healthy dogs. He repeated Eck's famous experiment in 1893. 16 years after Eck's paper, he created the egg fistula in dogs. Post-op, the dogs lost weight and lost their hair. Ataxia and convulsions preceded death, and he termed this meat intoxication. He did autopsies on the dogs, and he found atrophy and fatty infiltration of the liver. Liver atrophy and the neurologic deterioration did not occur when the shunt thrombosed. Very interesting studies. He should have won the Nobel Prize for this study. Those who cannot learn from history are doomed to repeat it. George Santayana. And again, so we go back and people decide ex fistula is going to be safe and should be done in man, when we should have been listening to Pavlov. So in 1946, Alan Whipple, here, the Valentine Mott Professor of Surgery at College of Physicians and Surgeons, Columbia University, he stated, portocable shunt operations are very difficult. But, I quote, certain of our patients have shown unexpectedly good results, and we have been encouraged to attempt more of these procedures in a group that are otherwise doomed. Blakemore reported in that same issue 14 portocable shunts and 2 operative deaths. He reported on one thing, however, is sure, and that is that unless the operation is carried out with infinite care as to details, and there are many, the chances of the portocable shunt remaining patent are practically nil. So let's flash forward to Dr. Warren's time. And this is a Kaplan-Meier survival curve for 2 groups of patients with portal hypertension and variceal bleeding. One, here in the dotted line, are the control patients. At that point in time, control patients were basically given blood. Early endoscopy wasn't very good at sclerotherapy, and a lot of times they didn't have any endoscopy at all. So basically it was just fluids, bloods, hope they survive. And here's the portocable shunts. And you can see the survival rate for portocable shunts is less than that for the control group. There was basically no difference in survival between the portocable shunt and medical therapy at that time. Why was this? The medical patients died overwhelmingly of variceal hemorrhage. Some of them died of hepatic failure. The surgical group almost always died of hepatic failure. Very seldom did they die of variceal hemorrhage. So although the ex fistula portocable shunts were very effective in controlling variceal hemorrhage, they still had the problem with liver atrophy, meat intoxication. So this is what Dr. Warren was studying. He was studying shunts. So here's the selective venous phase, the superior mesenteric artery catheterization. So you can see the SMV joining the splenic and then the portal vein. So this is hepatopetal blood flow. Post-mesocable shunt, you see no flow towards the liver. So non-selective shunts divert blood flow from the liver. If he occluded the portocable shunt, he could reestablish blood flow. And here you can see no blood flow, and here's blood flow after occlusion of the mesocable shunt. So here, 1966 and a 1967 publication, Dr. Warren and his colleagues Robert Zepper and John Foman presented this, the Warren shunt: selective transplantic decompression of gastroesophageal varices by distal splenorenal shunt. This was an amazing discovery. Here I show Dr. Warren with Dr. Zeppa, one of his colleagues on that infamous paper, and one of our previous Southeastern Surgical Congress presidents, Dr. Hiram Polk, who was a faculty member at the University of Miami. So we spent 1963 to 1971 at the University of Miami, wrote his seminal paper about the Warren shunt in 1966. This is a diagram from Dr. Warren's conception of the distal splenic renal shunt. In it, you divide the splenic vein and tie it off here. You anastomose the splenic vein to the left renal vein, thereby decompressing the varices through the spleen, through the short gastrics, and going back to the systemic circulation. You maintain, by cutting through the coronary vein, ligating the coronary vein and the gastroepiploic veins, you maintain portal hypertension and hepatopetal blood flow. You maintain portal blood flow. So then he moved to Emory, where he was the Joseph P. Whitehead Chair of Surgery at Emory. And he was there until his death, untimely death, in 1989. This is again a diagram, a picture of the distal splenorenal shunt. Again, the varices drain through the short gastrics, and you just have to dissect the splenic vein out from underneath the pancreas and divide it here and divide these big varices here to create a high pressure system and a low pressure system. Unique concept. So this is Dr. Mike Henderson. He was one of the two people that were instrumental as sort of Dr. Warren's right-hand man, like Bill Milliken. And he has a video.
That background, we head to the operating room, and here's Dr. Warren in his favorite location.
Dr.
This
Warren
operation is
operate.
commenced with a long left subcostal
Here
incision
is a
for access
single-site
to the
incision.
abdomen. Lesser
So
sac
it's
is
a large,
opened with the stomach
extended
mobilized
left
right up to the short
subcostal incision.
gastrics
You
to give
mobilize the
access to the
entire stomach,
pancreas.
leaving only the
In
short
this shot, you
gastrics
see the
way up on the
pancreas fully
fundus of the
mobilized
stomach.
from the superior mesenteric
And then you
vessel right
mobilize
out to
the
the splenic
entire
hilus.
pancreas
You appreciate the
expose
extent of
the splenic vein.
access.
Here's the
Splenic
spleen.
vein is then identified on the
Okay,
backside of
one
the
thing I
pancreas
could note
and dissection
here,
started. It's important
two
this is done
suckers
right on the
going
splenic
at the
vein,
same time. Sharp
below the
dissection.
adventitia. Here we're coming
You're
back to the
always
superior mesenteric
operating
junction.
underneath
It's a
blood.
very large inferior
You're always
mesenteric vein in
suctioning,
this case.
And
The main bits of the operation are taking
you're
down the small
always
tributaries into
suctioning,
the splenic vein, and
these
here's
are
one on the
difficult
posterior
operations.
aspect,
Here's a small
isolated,
posterior
tie going
perforating
around
vein.
it,
We
and
take
we'll
a
bring a
small
clip in
silk
to clip
tie,
away from the vein.
tie it against the
As
splenic vein. and
most
then
of them,
use a
however, on the
little metal
front
clip here
side.
distally.
Here we are
This is us
mobilizing around the
getting
junction of
around
the splenic
the
and superior
splenic
mesenteric vein. Getting control of this
And
junction
this is
is
a
really
critical
important.
maneuver here,
You can see the finger on the
because you've got to
backside
start
helping gain
isolating
control.
things.
With that fully
And
mobilized,
again,
decision
this
in
is
this
a
case was to
delicate
divide the
operation.
splenic vein early,
So
the
in this
ligation,
particular
and then a
case,
clip behind that
They
ligature.
decided to
The
clip
splenic
off
vein is then
the
divided,
splenic
as you
vein
see here.
at the junction
This opens
with
up the
superior
angle between the
mesenteric,
pancreas and the splenic
vein.
vein for further dissection.
And again,
This is the key part of the
dissect
operation.
at right angles to the
Dissection
splenic
in
vein
the
here.
line of the tributaries into the
constant blood
splenic
flowing
vein minimizes
until
the
you've
risk
got
of
the shunt
tearing. There's a
in
small
place and
tributary there.
decompress the varices
It's
and
isolated that
decompress the
way. A
portal
small
hypertension,
right angle clamp
you'd have
placed
bleeding.
around that.
And you just had
Again,
to
with
go.
the ligature placed in
And
that
somehow you
plane.
found your
This will be
clamp
tied down on the
around this
splenic
small
vein
perforating
side
vein.
and a clip on the
Take your
pancreatic
fine silk
side.
tie,
You tear these, you get a lot
tie
of
it up,
bleeding. Again,
clip
another
here against the
tributary, same
pancreas, and
movements.
go on and
Dissection
find
in the
more
line
veins
of the
until you had
vessel
enough length
minimizes the
of
risk of
splenic vein
tearing.
in order
Then
to do
isolate it.
the,
Again, come
procedure.
around that vessel
During the
delicately
time
with
I
the
was
right
there, we
angle
were
clamp,
working on
get the
complete
tie onto that on the splenic
splenic,
vein side,
you know,
and then clip it again
mobilization.
on the pancreatic
So the
side.
concept was
So a
to
lot
do
of
a
these small
splenic
tributaries that need to be
pancreatic
dissected.
disconnection. In other words,
Splenic
disconnect
vein gets fully
everything
mobilized
out
like that,
into
and
the
here you
hilum
can
of the
see it
spleen.
well mobilized
That
in this
was an
particular
exponentially
case.
harder operation.
We've now moved to the retroperitoneum
Now we're
to
going into
open
the
the
retroperitoneum,
retroperitoneal
take
space
it
and
between
identify the
clamps
left renal
because these
vein.
have a lot
Here
of
it is.
lymphatics in it,
Needs to be
especially
fully
in the
mobilized. The
cirrhotics with
adrenal
portal
is
hypertension.
ligated.
So
The
we
vein
had to
brought
tie all
up
those.
into a
You find the left
Stinsky
renal
clamp.
vein. Okay,
the vessel
you
is
tie off the
opened.
adrenal vein, you put on
Splenic
a
vein needs to be
Shunts clamp,
trimmed to
and then
size.
you
It's
open up your
important to
renal vein.
remove redundant
Then you
veins
take
so
your
there's no
splenic vein
kinking
and you
of
have
the vein
to
once the
tailor it so
anastomosis
it
is
doesn't
completed.
kink when
You
it's
can
put
see that
back
being
into
trimmed in
position.
this particular case. Here we are anchoring down the
Then
ends of
the
that
posterior row was
anastomosis,
a running,
bringing the needle back in at
like
that
a
left end to sew the
monofilament
posterior
suture of,
wall on the
proline.
inside, approximating the two
This
vessels.
is the
This is the
hardest
hardest
suture
stitch,
here,
putting that
that
first
first
one in that
suture.
posterior wall.
Then
Once
you
that
run right along.
is done, you can run along and complete the anastomosis.
And then the anterior row
wall is seen
is
here, is sewn with interrupted
507.
sutures.
Why
Here's the first one being
interrupted
placed on that anterior
Why not
wall.
just run it?
And here's the last stitch being
He
placed to
wanted
complete that
the vein to
anastomosis.
enlarge
Clamps
over
are now
time
off and
as
the
you
shunt
had
is
more
open.
blood flow,
Dr. Warren
forcing
looks at this
through
and knows
the
we have one more
enlarged
step to
gastric.
take. We go to the top side of the pancreas to
unless
complete
you
the
went up there and
devascularization.
took
Here's the left
gastric
gastric
vein, the
vein,
coronary vein,
the top edge of the
you didn't
pancreas being
disconnect it.
isolated and ligated.
Okay,
We
so
also
this
usually
was
clip
another
this on the
critical
bottom
portion of
side.
the operative
And here
procedure.
is a wide-angle
final
view
result,
looking
we've
at the
taken
splenic
off
vein
our
coming down to the
clamps.
renal vein
There's no
with a
further bleeding,
satisfactory
at least
distal
not much.
splenorenal shunt.
And we finished our operation. At Emory, they did a complete pre-op evaluation and then had the patients coming back to the clinical research center every year. Every year. He'd follow these patients with H&P, routine blood work, hepatic database, child's classification, endoscopy, visceral angiography, SMA, splenic, hepatic, wedge, left renal venogram, liver biopsies, hepatic perfusion index, galactose elimination capacity, which was a measurement of liver function, hepatic spleen mass, fasting plasma ammonia, amino acid profile. He worked these patients up. He studied them. He wanted to make a difference. He demonstrated that preoperatively, the patients that had hepatobetal blood flow, here you can see the SMV and the portal vein, had, after distal splenorenal shunt, continued even 10 years post distal splenorenal shunt in some patients. And this is his 10 years portal hypertension surgery at Emory. He could have stopped here because what does this show? This is the Kaplan-Meier survival curve for the selective shunts, 348 selective shunts up here, showing a 10-year survival rate of greater than 50%, far greater than the non-selective shunts, 156 non-selective shunts, who had a dismal survival of 30% here at about 7 years. So he didn't stop there. He insisted on studies and randomized trials. Here's his selective versus non-selective shunt, Kaplan-Meier survival curve. And what you can see, it's exactly the same when you do a randomized trial. The non-randomized trial was comparing apples to oranges. Child's Class C emergency patients to Child's Class A non-emergency patients. His other philosophy was you have to interpret and apply the data correctly. He learned from Nikolai Eck. We did studies, distal splenorenal shunt versus endoscopic sclerotherapy for long-term management of variceal bleeding. Prospective randomized trial to see what was better. First off, he looked at liver function. The liver function, as assessed by galactose elimination capacity, you can see pre-op was very similar. So the randomization worked, okay? They got patients with equal liver function. But 1 year, after 1 year of sclerotherapy, liver function improved in the endoscopic sclerotherapy group. It declined after the patients underwent distal splenorenal shunt. Okay, this is the killer. And this is what Dr. Warren presented. You have to evaluate the data. So if you look at the Kaplan-Meier survival curve for endoscopic variceal sclerotherapy, okay, here it's a little bit below 90%, maybe 89%, here 4 years out, 5 years out. Compared to distal splenorenal shunt, where you have a continued death rate, so you only have a 50% survival rate at 4 years. Remarkably better. But here's the kicker. Each one of these little arrows marks a patient that had continued variceal hemorrhage and had to be rescued by distal splenorenal shunt. Okay? So the real news was start out with endoscopic sclerotherapy. If they fail and bleed, then you can shunt them. And if you're really good at shunting, you can make this group survive much more than anything there to date. What was the status of the distal splenorenal shunt in the 1980s? It was the peak decade of implementation. Bleeding control of 90 to 95%. Survival was liver disease dependent. Liver disease dependent, yeah. Some patients under variceal, sclerotherapy still died of liver disease. Worldwide application in USA, Europe, Egypt, South America, Mexico, South Africa, China, and Japan. It was really worldwide that this was taken up. As an excellent operation when introduced, it was subjected to many randomized trials versus total shunts and sclerotherapy. Most patients, many patients, are better managed now with endoscopic therapy, transplant, and TIPS. It retains a very, very, very small role in a highly selected operation. After doing all this, I thought about this a lot, and I thought we ought to have a research committee for the Southeastern Surgical Congress to increase the quality and number of clinical trials presented and assist our membership in performing clinical trials, and to encourage our membership to adhere to the high ethical standards Dr. Warren espoused during his life. Dr. Warren, shown here as president of the American College of Surgeons, and you can see the eye patch on his eye. That was because he underwent enucleation of his eye and treatment for his cancer just before he became president of the American College of Surgeons. He went back operating and died in 1989. He insisted upon studies and randomized trials. He insisted on a careful interpretation and to apply the data to new patients. And he wanted to do what was right for the patient. I'm glad to say that Dr. Britt, when I presented this at our executive committee last afternoon, made an edict and said that, yes, we are going to form an ad hoc committee to explore the idea of a research committee for the Southeastern Surgical Congress. And so we'll be asking for nominations for the membership of this new ad hoc committee that I hope will help do these things. Thank you very much.